The study evaluate a new immunotherapy. REGN5459 is a bispecific antibody that has one binding site to BCMA on surface of myeloma cell. On the other hand, it grabs onto CD3 on T cells. The uniqueness of the molecule in the lower affinity to the T cells. In preclinical model, this lower affinity leads to less cytokine release syndrome, which is a main problem with the bispecific antibody in myeloma space currently. So we are taking this molecule to explore the safety and efficacy in a phase 1/2 clinical trial in patients with relapsed or refractory multiple myeloma. So patients in the study were all with active myeloma who have failed at least 3 prior lines of therapy, and that includes immunomodulatory agent, the proteasome inhibitor, and CD38 antibody, and have to have exhausted other therapies. There are 2 portions of the study. The phase 1 looked at dose escalation, safety profile, dose limiting toxicity, and recommended phase 2 dosing. For the phase 2 portion, we evaluate the efficacy based on response rate. So in the phase 1, we tested a total dose level. The agent is administered intravenously weekly. And before patients get to the full dose, they went through step-up dosing, which occur for the first 4 cohorts, low dose, split dose for week 1, week 2, and then patients get full dose from week 3 onward. Based on the pattern of the cytokine release, there's a little bit of an adjustment in the step-up dosing for that cohort 5 through 8, which made it a bit more tolerable with more manageable cytokine release syndrome. The recommended phase 2 dose was declared at 480 milligram. There was, maximum tolerated dose was not reached, and there was one patient who had hypoxia that wasn't related to cytokine release syndrome and was declared later to probably be related to COPD and occurrence of primary lung cancer. So ultimately, we expanded that 480 milligram dose to look at efficacy in the phase 2 portion. So far we have 43 patients enrolled totally. The response rate in the higher dose cohorts, the 480 and the 900 milligram, was 90.5%. And that includes 100% response rate we saw in the 880 milligram, which is the phase 2 dose. So the cytokine release syndrome, which was the primary reason why this molecule was brought to the clinical trial, right? We wanted to decrease the cytokine release syndrome. We continue to see cytokine release syndrome in this study, and at that top dose level, the incidence of grade 1 cytokine release syndrome is about 81%. All of them are grade 1 except for one grade 2. And that means that everyone had some fever, but only one patient had a change in their vital signs, in this case, a decline in blood pressure. Majority of patients were just treated with antipyretics. About 16% had this tocilizumab, which is a medication that is used for to dial down the inflammatory response that could occur with this particular treatment. And about 9% of patients had the steroid therapy. These were standard care, and the usage of the supportive care on the study was just left at the discretion of the treating physician. We're pretty impressed that even though there continues to be fever, it seemed to be relatively manageable, did not lead to significant delay in the step-up dosing, and majority of patients actually escalate up to full dose despite occurrence of their cytokine release syndrome. The sponsor is evaluating the future development of the compound. Ultimately, it is my wish to see that we continue to try to deliver this kind of treatment as safely as possible to our patients and make it accessible as well. Cytokine release syndrome is at the forefront of the problem because right now patients who are getting bispecific antibody usually get admitted and they receive step-up dosing as inpatient, which means that they have to go to a academic center. Cytokine release syndrome also could potentially be more difficult to tolerate when patients are more frail or elderly. So perhaps dialing the CD3 affinity is one of the ways to sort of explore the strategy to mitigate the CRS. Whether this particular compound is going to pan out in a larger clinical trial is yet to be seen. Now, the preclinical data that led to moving this particular compound forward to the clinical trial was also explored with a bispecific antibody against other tumor targets in other cancers. So if it turned out that CD3 lower affinity reduce the CRS, it may benefit other cancers outside of myeloma. I mean, to me, we're featuring the technology in a relatively small cohort of patients, and ability to deliver treatment safely and quite efficiently is what was impressive. We certainly had concern whether by lowering the CD3 binding, you were going to lose the efficacy, right? Because the bispecific technology required T cell recognition of the tumor cells to activate the T cells and clear the cancer cells. So if you don't activate the T cells very strongly, are you going to lose the efficacy? And in this case, it doesn't appear to be. It appears that, yes, we continue to see the cytokine release when we were escalating the dose, but the grading of the cytokine release syndrome actually did not increase. On the other hand, the response rate actually went up with the dose, and we didn't see the MTD, which was the success of the story. I probably should point out that there are other side effects outside of cytokine release that this agent that we experienced with this agent. So there's certainly hematologic toxicity, including some dropping in the blood counts. That's not necessarily out of expectation for patients with relapsed refractory myeloma. Infection continues to be an issue, particularly in these already immunocompromised patients. 60% or so of patients continue to have some infection. Majority were lower grade, but the primary organs that were affected the most tend to be the respiratory tract. There's some pneumonia, sinusitis, bronchitis. There's some urinary tract infection. And there were two patients who died from infection, including one from pneumonia, another one from COVID. So as we are exploring the bispecific technology, of course, there is a concern about T cell exhaustion. As you activate the T cells continually, these T cells actually lose their fitness. And that leads to perhaps not only lack of ability to continue to kill off the cancer, but also inability to prevent infection. So in the study, we now have an amendment coming out to decrease the frequency of the agent. So currently, this REGN5459 is given weekly for 16 weeks, and then it goes down to every other week until progression or incurable toxicity. But in the new amendment, we would go down after 24 weeks for patients who achieve VGPR or better to be just monthly, recognizing that perhaps we don't have to be as aggressive. And because in these patients with very deep response, they're likely to do very well. So how do we know that? We know that patients in this study who have responded or projected to maintain their response passing 12 months in almost 80% of them. So not only they could respond quickly, response rate is high, but also it's quite durable. So perhaps we can balance the convenience, decrease the longer term side effects, and still continue to maintain response. The whole idea whether using less frequent treatment and also using this lower affinity to the T cell, activating and expanding T cells in a more controlled way, whether that would also reduce T cell exhaustion and decrease infection is yet to be seen. Our study has median follow-up of about 9 months. So there's still data coming in. And there are about 12 patients who are still on treatment right now, with several that are actually passing 26 months mark. So we're pretty encouraged about that.